Good morning, and thank you so much for joining us for the Understanding Healthcare Disparities and Health Equity in Atopic Dermatitis Patients, Building Knowledge, Confidence, and Change in Primary Care Providers Wave 2 learning session. This is the Atopic Dermatitis Program team you will be hearing from today and throughout the program. We have Dr. Esteban Fernandez-Faith from Nationwide Children's Hospital, Dr. Patricia Treadwell from Indiana University School of Medicine, Dr. Chris Peltier from Pediatric Associates of Mount Carmel, Zainab Al-Abdali, our data analyst from ODH, and then I am your program manager. And in the interest of time, we will start with the agenda. Welcome, everybody. We will kick it off with Dr. Treadwell for the atopic dermatitis skin of color presentation. Dr. Fernandez-Faith will talk about other types of eczema and other considerations. Project resources will be covered by Dr. Peltier. We will have reminders from me and introductions if time is permitting, but there's a lot of good content today, so we will see about that. We can also cover introductions in the first action period call. And Dr. Treadwell, we'll start with you. I have your slides.
Thank you very much, Brooke. Good morning to everyone. I'm going to talk about some of the differences with when you see atopic dermatitis in skin of color and try to make some comparisons for you. Next slide, please. In the podcast, we mentioned that atopic dermatitis can be as prevalent as up to 20%. The literature supports that it is more common in Black children, and because of some of the changes in skin of color, it may present later. The erythema in particular is more difficult to appreciate in skin of color and may result in underestimation of the severity of the disorder and under treatment. Next slide, please. I'm just going to try to show some comparisons here for everyone to be able to look at. This is a Caucasian patient who has atopic dermatitis on the cheeks and has a secondary infection. So what you can see in this slide, first of all, is the background erythema, the scale that's present, excuse me, the scale that's present, and some of the honey-colored crust, which goes along with a secondary bacterial infection, which is not uncommon in atopic dermatitis. Next slide, please. This is a patient with skin of color who has eczema on the cheeks in a similar location to the previous patient. You can see that the erythema is not as visible. Next slide, please. And the areas, even though there is secondary bacterial infection and crusting, which I'll show you on a close-up, is not, you can't see the erythema as well. So there's more of a hyperpigmentation with it. One other thing I wanted to point out on this slide is typically with atopic dermatitis or eczema, the diaper area tends to be clear. This is not 100% true, but it tends to be clear. So you can see in this particular child, the diaper area is fairly clear, where other areas of the body are more involved. Next slide, please. And here's the close-up that I mentioned. You can see the crusting from the secondary bacterial infection. You can see on the leg itself, there are some fissures that are present. All of this is part of having atopic dermatitis, and I'll talk a little about the scoring in at the end of my presentation. But you can see here that the erythema is not as noticeable. Next slide, please. So here's a very typical eczema atopic dermatitis in the antecubital fossa for a Caucasian patient. Next slide, please. A similar patient also involving the antecubital fossa and an area here on the flank. Next slide, please. In a patient with skin of color, what you can see, I'll talk a little bit about the papular eczema, which I think Dr. Dr. Fernandez-Faith is also going to mention. But you can see in the upper part of the slide, the eczema that's there, it's a similar morphology, but the erythema is not as noticeable and maybe a little more noticeable to see the scale. And then again, in the lower part of the slide, there are some papular lesions. Next slide, please. So papular eczema can be seen in skin of color and also in this Caucasian patient, as you can see. Papular eczema may be present in the same areas of involvement that you would see with the more typical eczema, but has these papular lesions that are scattered. Next slide, please. Here's the same type of eczema in skin of color, and you can see the patient has been itching, as noted by the erosions on some of these lesions. So the patient's been scratching these areas. But again, this kind of papules, eczematous papules is what we call them, that are in a distribution where we might typically see eczema. Next slide, please. Another patient with papular eczema, a little bit of scale with it, and also some evidence that the patient has been scratching. Next slide, please. So back to, this is the first patient again. He actually was a little older, but had nummular eczema, which is what is depicted here in this slide. If you show that, please show the next slide. On close-up, these again, this patient had a fair amount of secondary infection that you can see here, the honey-colored crust. The eczema is in a nummular or circular shape, and then the honey-colored crust that goes along with it. Next slide, please. Here's a patient who has an eczematous dermatitis. Again, pointing out, I'm saying this over and over like a broken record, although the millennials who may be on the call have no idea about a broken record, but I'll say that you can't see the erythema, and even though this is widespread, it's not as noticeable as what we would see in lighter skin. Next slide, please. One other type of eczema that we might see is what's called Psoriasis alba. This in skin of color, this will tend to come up in the spring. What happens is there's mild eczema in these hypopigmented areas, and then the surrounding skin gets darker when the child is exposed to the sun. So the face is a common place that we might see this. They're irregular. They may have some scale associated with them. Again, the skin on the outside of this is a little bit darker. Next slide, please. Lichenification, I wanted to go ahead and give a definition. We've talked about this a little bit associated with atopic dermatitis. With prolonged rubbing or scratching, the outer layer of the skin, the epidermis, becomes hypertrophied or overgrown. This results in thickening of the skin and exaggeration in the normal skin markings, giving the skin a leathery bark-like appearance, shown on the next slide. You can see here that, again, the erythema is there, but pretty not real noticeable. I think one thing that Dr. Fernandez-Faith talks about is that we should train our eye to look for the erythema. And there is some on the anterior portion of the ankle, and then some crusting also. What you can see is this thickening of the skin and the emphasis on the skin markings in this particular patient because of prolonged atopic dermatitis and prolonged rubbing. Next slide, please. I also wanted to point out in skin of color that the dyspigmentation can be an issue. This was actually an adult patient who still had eczema. And when I asked what they were scratching with, they described that it was the the back end of a butter knife. And so you can see the scarring that's here, some hyperpigmentation and some hypopigmentation. And this may be fairly persistent on a patient who continues to scratch. And next slide, please. Also, some areas of lichenification in this particular patient, more of the hyperpigmentation and less of the erythema. Okay, next I'm going to talk about some of the, I'm sorry, I put in this slide from a youth outreach worker who I thought sort of captured some of the issues. That rather than looking at America as a melting pot where the characteristics of different cultures are lost, the country should become more of a stew where the meat is still meat and the carrots are still carrot, but the flavor is enriched by the presence of all the ingredients. Okay, next slide, please. So there are a number of different indices that are used in clinical trials. One that I'll emphasize and that we can use in our assessment is the Investigator Global Assessment. So next slide. With the Investigator Global Assessment, there's a 5-point scale and half points can be allowed. Next slide. Has the indication, here's the table that'll be helpful while you're trying to make an assessment of the eczema or atopic dermatitis after treatment, before treatment at baseline, and as the information is progressing. Okay, and next slide. So clear or 0, you see no erythema, no induration, no lichenification, and no crusting. There may be the changes that I described about the pigmentation. Those can be present even when the eczema is not active. Next slide, please. So 1 is barely almost clear. So you can see some erythema, but it's not perceptible. But there may be some minimal lichenification, but there's no oozing or crusting for 1. Next slide, please. Mild eczema, you will see some, and here's where we'll kind of train our eyes for skin of color, that there is some definite erythema as part of 2, but maybe not with our eyes not trained, not see that. And there may be some lichenification, but we're not into the oozing or crusting for 2. Next slide, please. So here in skin of color, the erythema is not as noticeable, but there is some induration and there's some lichenification, but still we're not to the point of oozing or crusting. Next slide, please. So here's a moderate that fits under 2. And so here is a patient where you can see the erythema. There's some oozing and crusting may in fact be present with moderate, when we are looking at 2 with moderate eczema. Next slide, please. So this is 3. This is more severe. And again, as you see on my slide, it says marked erythema, but you have to train your eye to see the erythema. But I think you can see how thickened the skin is in this case. There's lots of scale that's with it. There's lichenification, particularly there on the elbow. It's pretty widespread, and you can have oozing or crusting. Next slide, please. So again, a 3, but severe. Here you can see the erythema, again, some induration, and some lichenification on this particular patient. The widespread nature of the disorder fits into this category, and again, oozing or crusting may be present. Next slide. Okay, that's the end of my presentation. If anyone has questions, I can answer those at this point.
Thank you, Dr. Treadwell. Yes, participants, feel free to unmute and ask your questions. You are welcome to put them in the chat as well. But if you think of something later, I'm happy to pass any questions to Dr. Treadwell to answer offline. Okay, I think I waited the 7 seconds. Hearing none, someone will think of something and we will get back to you. Dr. Treadwell, thank you so much. I know you have to go and appreciate your time today. Okay, Dr. Fernandez-Faith, we can move on to you.
Okay, thank you very much. Yeah, I wonder what the nowadays equivalent of a broken record is. That's that's an interesting observation. So let's go to our next slide. So it is, most of our patients we're gonna be able to recognize the typical patterns of eczema, the typical distributions, but there are some patients that present with different types of eczema, and it is definitely very important to recognize those other patterns, like this nummular eczema, which Dr. Treadwell did mention in her presentation as well. So nummular means coin shaped. So we see these patients with this kind of round or oval plaques and patches. They tend to be pretty itchy, as eczema usually is. They can be thicker. And you can see the patient on the right has multiple of these kind of coin shaped patches or plaques. It is common to see this type of eczema along with the typical presentation of eczema. So these other types of eczema we're gonna often see in combination with the more typical presentations as well. Next one, please. And these are two patients that I wanted to highlight the differences between patients with skin of color and patients with lighter skin. You can see how that erythema is much better kind of recognized, more easily recognized than the patient on the left who has a much lighter skin type. The patient on the right, you see more of that hyperpigmentation. That erythema is a little bit more difficult to recognize. But these are two patients with nummular type of eczema. Next one. Another type, which Dr. Treadwell mentioned as well, is papular eczema. And this is very common. We can definitely see it in all different skin types, but we tend to see it more in kids who have darker skin types. So I definitely see it more in African-American patients. I definitely see it more in Hispanic patients. And there's a couple of different kind of presentations, like the patient on the left has more of these skin-colored, very small papules. On the trunk, the patient on the right has a little more hyperpigmented papules. They tend to be pretty what we call monomorphic, meaning each papule looks exactly like the next one, and they can be pretty itchy as well. Something that we see very commonly in patients with darker skin types is what we call follicular prominence, and what that means is that just the hair follicle, the skin around the hair follicle, looks more prominent, and we usually see that on the trunk. So it's almost like it looks like they have goosebumps all over the trunk, and we see it often in kids who have kids with darker skin types who have eczema as well. Next one. Another form of eczema, which we can see either by itself or we can see along with more typical forms of eczema, is dyshidrotic eczema. So dyshidrotic eczema presents with these very kind of deep-seated vesicles. Sometimes they look very clear, and what's very characteristic is to see it along the sides of the fingers and the toes. So it's something that affects hands and feet. It can be very bothersome, very itchy. These patients tend to suffer a lot from, especially nowadays, using hand sanitizers that are very irritating to the skin because their skin is open and they have cracks, and it can be quite an issue for them. And this is a type of eczema that usually requires kind of higher potency topical steroids because the skin on the hands and the feet is much thicker. So we need to use something that is a little bit stronger to get this inflammation under control. Next slide. Now there are other considerations or other presentations or other different types of inflammation that we often see along with eczema. Seborrheic dermatitis is one of those. So seborrheic dermatitis can also be considered a form of eczema that has a different type of location or distribution. We'll often see seborrheic dermatitis mostly in infants and adolescents. And you can see the adolescent on the left. It's very common to see it on the scalp, what we normally call dandruff or cradle cap in little ones, dandruff in older ones. We see it on the scalp, we see it along the hairlines, but also around the eyebrows, around the nose. Those are very, very common spots, around the ears as well. And in patients with darker skin types, it can present more with hypopigmentation. So these lighter patches that tend to have very, very mild scaling as well. So it's very common to see it there. And we know that seborrheic dermatitis has a yeast component to it. So there's like a yeast overgrowth that tends to drive this type of inflammation. In little ones, we see it as what we normally know as cradle cap. So very common to see on the scalp, often a little bit on the face as well. Next one. But also in the folds. So we see it in the neck, in the axillary folds. Sometimes we see it in the diaper area. We call this as also intertrigo. So Dr. Treadwell mentioned that eczema or atopic dermatitis typically spares the diaper area, but some infants will have involvement of the diaper area if they have this seborrheic dermatitis or intertrigo component as well. And this tends to be driven more by yeast. Next one. Contact dermatitis is also something that we see fairly commonly. Contact dermatitis is something that we could see either by itself or we could see it in patients who have eczema. There are two main types of contact dermatitis. We have irritant dermatitis, which is most common, and we have allergic dermatitis. So something that we see all the time in infants and young toddlers with eczema or without eczema, but definitely in patients with eczema, is this irritant dermatitis around the mouth. And parents usually come very concerned because they think, oh, it's an allergy to a food, because it always gets worse when they eat certain foods. But this is really an irritant reaction. And even saliva can be extremely, extremely irritating to the skin. And something that I want to point out here with these patients is you can see the difference in the redness or the erythema, how much better you can recognize that erythema on the patient on the right with the lighter skin type, but the patient on the left, he has darker skin type, and that erythema is a little bit more subtle. It might even look a little bit more purple or violation. So, but it's important to recognize that they both have significant inflammation or irritation around the mouth. And so parents are usually very concerned that this is a food allergy, but we can reassure them that this is an irritant reaction from saliva. Certain foods definitely, especially some acidic foods. I always tell them tomato-based type of foods or some type of citric fruits as well. Those tend to cause quite a bit of inflammation. So important to put a really good barrier around the mouth before they eat. Next one. And then the other type of contact dermatitis is allergic contact dermatitis, which again, we can see either on its own by itself, or we can see it in patients who have eczema. So these are two adolescents with history of eczema, where they presented with this very kind of well-demarcated plaques of erythema and scaling, very, very itchy with a very similar distribution. And so they actually have an allergic contact dermatitis. The patient on the left is actually allergic to his shampoo. There's an ingredient in his shampoo that he's allergic to. So we need to find shampoos that do not have that type of ingredient. And the patient on the right, as you can see from the hair color, this is a patient who is allergic to the hair dye. And so whenever she dyes her hair, she gets this really, really bad reaction, which is an allergy to the PPD component of that hair dye. And they both have eczema as well. But again, you can see this in patients with eczema or without eczema as well. Next one. Or this patient, kind of very interesting pattern. You can see a very kind of perfect crisscross on the back. She has an allergic contact dermatitis to her sports bra. There is a material in the fabric that has kind of more that neoprene type of material that she is allergic to. So it was a very interesting, very characteristic pattern of an allergic contact dermatitis. So these are other types of inflammation. These are other types of issues that patients with eczema could have as well. Next one. Now, while it is very important to know what does eczema look like, what this typical eczema looks like, which I know you guys know very well, but also very important to know what other forms of eczema are there. It's also very important to know what is not eczema. So what is in our differential diagnosis when we're seeing these patients? Next one. And one of those common ones that we see is psoriasis, although much less common in pediatric patients than atopic dermatitis. And psoriasis is classically characterized by this thicker, very kind of white, silvery scale. That's a textbook definition or characterization of psoriasis. This silvery scale and tends to have very particular distribution, mostly on the elbows, on the knees, lower back, the genital area. The scalp is a very common area. The face as well is a very common area. And next one. Now, in patients, particularly in pre-adolescent patients, you might not see that very thick white silvery scale. Psoriasis in younger patients might present with thinner plaques. It's not quite as thick as in adolescents or older patients. How do we differentiate eczema from psoriasis? Psoriasis usually presents a little bit later, usually more in the school age years, typically. It can present sooner, but usually in school age years. Versus eczema, it tends to present much, much earlier. We usually see it started in infancy or in the young toddler years. The location is also characteristic for psoriasis. I mentioned mostly on extensor surfaces. The face, the scalp are very common areas, the genitals as well. The scale of psoriasis tends to be thicker versus eczema is a much finer scale. And the symptoms are also different. Eczema is very, very itchy, as we all know. Psoriasis can be itchy, but typically not as bad as eczema is. But it is important to recognize that psoriasis can be bothersome as well. Next one. Then the other kind of class of, or the other category in the differential diagnosis are infections and infestations. Scabies is one that we see fairly commonly, and sometimes, especially in infants or young toddlers, can be somewhat tricky to differentiate from eczema. Sometimes they will be referred for eczema, but they actually have scabies. Some points here to maybe help you with that differential diagnosis. In infants and young toddlers, it's very, very common to see scabies affecting the palms and the soles. So if you see a lot of involvement of palms and soles, think about scabies. Eczema usually doesn't go to the palms and soles in young patients. Older patients, yes, but in young patients, not as much. And with scabies, we usually see a combination of morphologies or lesions. We see some scaly plaques, but we also see some papules, some pustules. So there's a combination of things. It's a little bit more messy. You see, it's not just one pattern. You see multiple patterns. Of course, if there's a family history, like, oh yeah, somebody else in the family had this rash, then it's more indicative of some infection or infestation. But it's also important to recognize that sometimes nobody else in the family has the rash. It's only the patient that you're seeing. Next one. Ringworm is another one that we see fairly commonly. And so ringworm, what's characteristic is you have this ring of erythema with scaling with that central clearing. And here again, I want you to recognize the difference in that redness or erythema in a patient with darker skin versus a patient with lighter skin. On the left, that erythema is much more easily recognized on a lighter skin type. But the erythema or that inflammation in darker skin types usually presents a little bit kind of darker, even more purplish in color. But what's very characteristic is that central clearing that's very characteristic of ringworm. Typically not something that's been going on for years and years. Usually the history can also help you with that differential as well. Next one. But somebody with eczema is also allowed to have ringworm. And so these are two patients with eczema, actually, who started to get a rash on their faces, and their parents thought that, oh, it was just an eczema flare. They started using the topical steroids, and it actually got worse. So they come to you, and now it's all kind of messed up. That look, that central clearing is gone. You can still see a little bit of that trailing border, but that clearing in the center is gone, and that's because the parents were using the topical steroids for a presumed eczema flare. And this is what happens when ringworm is treated with topical steroids. It usually gets worse, and really the morphology or the pattern gets a little bit kind of like messed up. It's not as clear as somebody who has not been treated with topical steroids. Next one. Now, a tool that you will have available is the eczema action plan. So this is a tool that you can provide to your patients to kind of guide them and tell them kind of what to do when for the care of their eczema. Next one. And so the action plan is divided in 3 zones. We have the green zone, the yellow zone, and the red zone or rescue. So the green zone is we're just maintaining the eczema, maintaining the skin. It's very well controlled. The yellow, we need to start to do something. Things are starting to act up. And rescue, there's something else going on here, or things are getting much worse. So let's look at a little bit more in detail to each of these zones. Next one. So green zone is when things are pretty clear or very, very mild. So here we want to make sure that we are continuing to use very gentle products on the skin. We're maintaining a pretty good skincare routine, using fragrance-free cleansers, using moisturizers very regularly without any fragrance, without any perfumes. I think it is important to always educate the parents and the patients that moisturizer, that gentle skincare is going to be an ongoing part of the eczema care, even if the eczema is completely clear. We want to make sure that those baths are short and not too warm, kind of lukewarm water, and we're just patting dry. So keeping just a good skincare routine, that is our green zone. Things are pretty well controlled. Next one. When things are starting to act up a little bit, there's more redness, more roughness to the skin. There's more inflammation. There's more irritation. This is when we have to, okay, let's start using our topical medications. And these are some recommendations, but of course you have the flexibility of using other classes or other topical steroids as you think it is appropriate for that patient. These are kind of recommendations on the lower end of potency, but you can go up depending on each situation. So this is when we really need to start to use our topicals so we can start to get that inflammation under control. Of course, always continuing the regular skincare, making sure that we're keeping that skin very well moisturized. The next one. And then we get to the red zone or rescue zone. This is when things are worsening. Either the eczema is really not responding to our first line or maintenance type of medications, or there might be something else going on. So if the patient is saying it's more painful than itchy, that should indicate that there might be an infection going on. There's crusting, there's that kind of honey color crusting, then you should think maybe there's an infection going on here. Eczema tends to get infected very easily. So here we need to increase the potency of the topical steroids, but if you think there is an infection going on, for example, then this is when we can add antibiotics if those are appropriate in this patient. I want to mention here, we included here the use of oral antihistamines. We don't want to give the parents the idea that the oral antihistamines are going to cure the patient's eczema. We are relying less and less on oral antihistamines really for symptom control. We really want to concentrate on getting the skin under control. Really, the antihistamines are going to be a very, not a great band-aid, but maybe a little band-aid to help with the symptoms. But we want to try to minimize the use of antihistamines as much as possible in these patients, unless the patient has other allergic conditions. Let's say they have allergic rhinitis or environmental allergies, then the non-sedating antihistamines are going to be very important. But for the general care of eczema by itself, we really don't want to recommend using antihistamines a lot, maybe just in some bad flares on some specific cases. And I think that is it for my part, right? Yep. Any questions? I'd be happy to cover now or later or offline.
Great content. Dr. Fernandez-Faith, thank you so much. Does anybody have any questions?
I noticed on the red zone, you guys had like wet wraps and bleach bath instructions. Do you guys have those like instructions somewhere that we could give our patients?
Yeah, I don't know if that is included in the tools, but we can definitely make that available for sure. So the wet wraps can be very helpful to get a flare under control, even just to moisturize the skin, just to use it with moisturizers. And bleach baths definitely, particularly for patients who tend to get infections on a regular basis. I definitely find bleach baths to be very helpful as well. So we can certainly make that available for sure.
Definitely. We don't have anything. We did not have anything like printed up for that, but we definitely could. Esteban, we might need your help from you or one of your clinic nurses, but we could definitely get that.
Absolutely.
Do you sometimes use mupirocin or more of an oral antibiotic when you're suspecting infection?
Yep. So that's a great question. And sometimes with eczema, it's tricky because sometimes an infection may not present as an obvious impetigo area or an obviously impetiginized area. It may be a little bit more subtle. If the infection is very localized, then I think a topical antibiotic would be reasonable. Something that we have to be careful about is that sometimes parents get too liberal with topical antibiotics, and then they're going to be using topical antibiotics all the time. And then that's where we get into obviously the potential risk of antibiotic resistance, which of course we don't want to get to. So it's very important to provide that education to the parents. If we're going to use a topical antibiotic, a limited amount of time, just until that area clears. So I think there's definitely a role for topical antibiotics in certain situations. If the infection seems to be more generalized, then a course of oral antibiotics might be helpful. In general, I recommend, if possible, to get a culture. A culture can be very helpful to determine if the antibiotic is the right one, or if things need to be changed. Very frequently in patients with eczema, just because their barrier is not perfect, bacteria gets in there all the time, and the bacteria itself can really drive the skin inflammation. So sometimes a bad flare could be driven by bacteria, and very often even a short course of oral antibiotics can really settle down that inflammation. So in the presence of an infection that is more generalized or more widespread, an oral antibiotic would be the way to go, unless it only, I would say, in very localized situation, very localized suspected infections, then a topical might be better way to deal with it, but being mindful to try to be to limit the use of the topical antibiotics. Great questions.
Any other questions?
I have a question. Do you find sometimes that ointments or petrolatum is irritating with kids who have papular eczema?
Yeah, that's a great question. I think the formulation is very, very important to consider, and we covered some of that information in our podcast. That is a great question. So we either have, so the two main classes or formulations that we use for eczema are ointments or creams. So ointments are going to be greasier, like Vaseline, more petrolatum based, which in general tend to be preferred for patients with eczema. They already have very dry skin, very irritated skin. So ointments tend to be less irritating. If anything, creams and definitely lotions tend to potentially cause a little bit more irritation or a burning effect early on. And so if anything, I noticed the opposite. Usually with ointments, there's not a lot of burning sensation or irritation. Very often parents will come in and say that their kid hates their cream because it burns, and usually it's because there's a cream formulation. If you notice though that an ointment is causing more irritation, more itchiness, maybe making the eczema worse, the other consideration is, could this patient be having a contact dermatitis? So there are some ingredients in some of the ointments that could actually cause an allergic contact dermatitis. So that is a consideration. In general, patients with eczema tend to prefer ointments versus creams.
Any other questions? Okay. If you think of something, please don't hesitate to share, but we will continue to move on. Thank you, Dr. Fernandez-Faith. On to Dr. Chris Peltier about project resources you will see.
Thanks, Brooke. Before I kind of share, I just have a couple of slides I wanted to share. Some of it's going to be a reiteration. Just wanted to remind everybody of some resources that you already have access to. Obviously, we've made some references to parts 1 and 2 of the podcast that we recorded a few weeks ago with both Pat and Esteban that really delve more also into not only diagnosis, but treatment and management, also with a focus on social determinants of health and other health equity issues. Brooke and I recorded the pre-work kickoff webinar last week that I think you all have a link to. And again, that's sort of, we go through the project in detail. And then of course, honestly, so I was the medical director for Wave 1, as I talked about in our pre-kickoff webinar. And one of the greatest resources that you will have by participating in this project is just access to both of our pediatric dermatologists on sort of a monthly basis. So they really, truly are a great resource. Next slide, Brooke.
We did get a question in about a clinical question. Do you want to cover that now or at the
Yeah,
end?
go ahead if Esteban wants to take that.
Okay. Any suggestions for treating the, oh gosh, help me out with this.
Hypopigmentation. Yes, that is a great question, especially in patients with darker skin types. That is often what concerns the parents the most. They're going to come in and they might say like, well, I can get the eczema under control. But what I'm very concerned about is these light spots or dark spots. Some patients, they have more of those dark spots after the eczema has cleared. I'm just going to remind everyone, if you can just be aware of your surroundings and maybe turn off your camera if you're not in the best location. So with the hypopigmentation, the most important thing is to make sure that we keep the eczema under very good control. Very often parents will have the concern that, oh, it was the medications that caused the hypopigmentation. It typically is not the medication, even the topical steroids is mostly due to the eczema. And so that is what's really, really important to educate and say, like, the most important thing is to get the inflammation under control. We need to use this medication so that we can get the inflammation under control. As long as the inflammation is kept well under control, that hypopigmentation or hyperpigmentation will completely resolve eventually. It's going to take some time, it's going to take a while, but it's going to resolve. So maintaining a good moisturizer, maintaining a good skin barrier on that area, keeping the inflammation under control is going to be our best way to make that hypopigmentation resolve.
Thanks, Esteban.
Thank you. Okay.
All right, next slide, Brooke. So one of the first things that you might want to do, if you don't already have it, is for this project, is creating an atopic dermatitis specific EMR protocol. So I think I talked a little bit in the pre-work webinar. My practice, for instance, when we did this, we had a generic rash protocol. And so when I started this project, one of the very first things we did was create, like I said, an atopic dermatitis specific. And so some of the things you may want to consider when you're building that template. And for those of you that are on Epic, we had a lot of our participants that were on Epic, that were in hospital-owned practices, and they were sharing protocols once they sort of built them. So again, one of the advantages to sort of being part of this learning collaborative. So some of the questions you may want to specifically list out in your history: when did the rash first appear? What was the original location and what did it look like? Has it changed in appearance or in location? What topical treatments have been tried and what were the results? Obviously symptoms. Is there pruritus? Is there pain? Is there dryness? Is there swelling? And then, so maybe delving into some of the psychosocial aspects, which we'll talk a little bit more in a minute. Is the child having sleep difficulties? Are there any behavioral or emotional problems that may be related to the child's diagnosis of atopic dermatitis? And then is there a previous history of atopic dermatitis, or is this sort of a first presentation? Next slide, Brooke. And then moving on to a specific physical exam, and just sort of, most of our protocols and even our rash protocol just had a spot for skin. I put some specific prompts in here, and some of these may look familiar. Dr. Treadwell we used the IGA classification that Pat went over. And so in my protocol, We have spots for erythema, with the choices being barely, slightly, clearly, or markedly perceptible. We talked about, documenting, is there any induration and papulation? Is there lichenification? And again, sort of specifically, commenting on the severity, because that's going to be important when we get into that severity, calling how severe it is. And then, is there any oozing or crusting? For the diagnosis, we only listed atopic dermatitis as the only choice. Of course, there is an option to write in if there was something else. But the reason, and we listed AD, is because as you're starting to do data collection, you're going to need to have somebody in your office pull those visits where atopic dermatitis was the diagnosis. So if you specifically have that listed as the choice, you're going to be able to capture those patient visits. Again, we decided to use the IGA scoring for severity, which is why Dr. Treadwell sort of went over that. And again, we'll have these slides available for you to refer back to. Again, making a diagnosis of clear or almost clear, mild, moderate, severe. I'm going to talk in a minute about the quality of life index, but we put an order in for that. And then these are specific things that we had listed under our plan that you could check and then make some comments about. What did you recommend as far as skincare routine, use of cleansers or moisturizers? If you prescribed or recommended a topical corticosteroid, what was that and what were those directions? If you used a steroid sparing agent, same thing. We had a box for if you, and we would encourage you to, but did you complete an eczema action plan and give it to the family? And then did you provide the family with any atopic dermatitis educational handouts? Next slide, Brooke. And the reason I set my protocol up that way was this is some screenshots of the atopic dermatitis data collection tool, which is going to be, you're going to complete online. And so as you will get to know this data collection tool a little bit, you'll see that several of the components of this were basically what I used to build the template. So as you're sort of doing your chart reviews and you need to enter the data, you literally will just have to look at those protocols and you'll have all the information that you need to enter into the data collection tool. Next slide. So again, you can see some of the things, did you complete an eczema action plan? Did you complete a quality of life screening? Did you make a diagnosis? Was the severity documented? Were symptoms documented? And then it just made it very, very easy, and the two align. So again, happy to share, if anybody wants, I can sort of send you a PDF of what our protocol looked like. But as you're looking at this data collection tool, that was how we built the protocol, and it made it so easy. I was the one that did the data entry, and it just made it really, really easy. The other thing I didn't list on there is, was there a referral made to dermatology, yes or no? So you also have that information. Next slide, Brooke. I'm not going to go into this in depth. Esteban did a really nice job. Probably I think the neatest thing, the thing I think I was most proud of from Wave 1 was the fact that our team sort of created this eczema action plan. You are welcome to use this. You are welcome to make your own and tweak it. You do not have to use this one, but this I think worked really well for my practice. And I think it was probably one of the things that my partners felt they got the most out of was using this eczema action plan. Really helped sort of communicate what to do when for your patients with atopic dermatitis. Next slide. Something that was a little bit different that we did in Wave 1 was we also focused on sort of some of the behavioral and mental health aspects of atopic dermatitis, both atopic dermatitis specifically, but also sort of dealing with a chronic disorder, which, as you know, atopic dermatitis is. So one of the things we offered was to do a quality of life and using a quality of life screening tool. And there are 3 different versions. There's an infant that's applicable up to age 4. There's a child version for age 4 to 16. And there's both a cartoon, which I actually liked for most kids sort of in that young school age range, as well as sort of a written version. And then there's a form for teenagers 12 to 19 years of age. And there's the website. And again, we will have these slides available. You can download those directly from the website. There are some versions for different languages that are available on that website as well as the instructions for how to score it and what's a normal or abnormal quality of life screening tool. Next slide, Brooke. And this is just an example. I took the childhood quality of life, which is again from age 4 to 16, and these are the questions. And it's a 4-point Likert scale that the kids answer. And I won't read all of these. You can sort of read these for yourself. But it talks about symptoms. It talks about were they embarrassed? Has it affected friendships? Have you been teased or bullied? Is it affecting sleep? Have you avoided things that you normally would do, like swimming or sports, because of your skin? So it just sort of helps give a little bit of sort of that behavioral psychosocial insight into how significantly these symptoms are affecting patients. Next slide, Brooke. And then here's the cartoon version. Again, very similar. You can see the Likert scale. It's very much quite a lot, a little, or not at all. And again, I thought this worked really well for some of the younger kids to sort of, help them fill that out. Again, there's an infant form for the parents, and then there's a teenager quality of life that you also can use. Next slide, Brooke. And that's pretty much it for the resources. Does anybody have any questions? Again, I'm happy to share my protocol. And that was one of the things as we sort of went through this with some of the action period calls is, different practices would share their protocols, their things that worked for them, things that didn't work for them. So I'll pause and see if there's any questions.
Thank you, Dr. Peltier. While participants think of questions, I do want to say that any resource that we are referencing, we are going to eventually roll those out. We are making some updates to some of them. So maybe you're thinking that you don't have something in your hand quite yet, but we will be getting rack cards, for example, in your hands, an updated version of the Eczema Action Plan. So those will be rolled out as the program gets started.
That's good. I was remiss. I did not put pictures of some of the rack cards, but we will get those to you as well. But those are really nice for you to sort of just give to your families and your patients.
Yeah.
I had a question for Dr. Faith.
Okay.
Just like with all it seems like there's a lot of commercials now with Dupixent and other things are coming out for eczema, but it seems like, what criteria do you guys use to say someone needs Dupixent? Because it seems like, I know typically, yes, they have to fail the typical measures, but then I guess what severity level would they qualify for some of these newer treatments that are available?
Yeah, that is a great question. This is really an exciting time for eczema in that sense, because we used to not have a lot of newer medications or great medications that work very well for these patients. We're using very traditional, even systemic medications. But now there's dupilumab, as you mentioned. This is a systemic medication available for specifically for eczema, and other also systemic and topical medications are coming down the pipeline for these patients. Specifically dupilumab. So dupilumab is FDA approved to treat atopic dermatitis. It's also approved to treat asthma. And so not unusually, we'll see patients who have both eczema and asthma. And so this would be a good, if neither one are well controlled, this would absolutely be a very good medication that could tackle both. Dupilumab is FDA approved to treat patients who have moderate to severe atopic dermatitis who have not responded to topicals. So it really has to do with the severity of their eczema, not a medication that we really want to use for patients with mild eczema that is very well controlled on topicals. So we really want to keep it more for the moderate to severe patients. But having said that, also we have to take into consideration how is the patient being affected? What is the quality of life? So even if it's not maybe a severe eczema, but their quality of life is very poor, their school performance is it's going down because of their eczema. Those are definitely other considerations that we take into account to decide whether we need to step it up to a systemic therapy. There's another type of treatment called phototherapy that is like an in-between. It's a step up from topical, not quite systemic therapy. So phototherapy is with narrowband UVB, and that might be a good option for many patients. Not always super practical because they have to do it twice a day in a doctor's office, but that's another possibility. But you're absolutely right. We're using more and more Dupixent. It's overall very safe medication, very effective medication. but typically we use it for the more moderate or really more severe patients.
Thank you. Any other questions for Dr. Fernandez-Faith or Dr. Peltier? Dr. Treadwell did have to hop off. Okay, throughout the program, you will have access to our medical experts, which is a good thing, which is a very good selling point for this program. So anything that you think of, you can email me and I will get you an answer from them. If you don't mind, we don't have time to go around the room and do the introductions, but while I do the reminders, if everybody could in the chat write their name and where they're from and your email address if you were forwarded this invitation to this learning session. There are some names on this call, which is great that I don't have your email. So if you are working with a provider that got the information, if you could just share that in the chat, that would be great, please. And I just want to go through reminders about the rest of November and into December about the program. It was mentioned by Dr. Chris that we recorded the pre-work webinar, and that is currently available for your review at your leisure on the AD program website. If you could just listen to that by the end of November to help gear up for kickoff. And then the website address, I can give that to you, or it's also in the recruitment packet. Also referenced in a really good resource that we did early in this program was the AD podcast series. Really turned out well, really proud of this one. It is also available for you to get more education around AD and eczema. If you could put that in your November to-do list as well, that would be great. You are to schedule a kickoff call with me just to answer any questions that you have, any outstanding items to get you truly primed to kick off the program. And then if you could start doing the pre-work survey and the baseline data collection survey, we will give you until December 15th to get this information. This information will be very helpful for you to get started and then start our data collection for Zainab to start analyzing for our program. So all the links you should have in the recruitment packet, but if you were forwarded this invitation and don't have the information and you will be participating, I will be happy to send that to you. Thank you for those who have put the information in the chat. We don't have to do the introductions today. We can do those on the action period call and when we talk one-on-one. So if anybody has any outstanding questions clinically or based on the program.
I just had a question. So I know right now we're doing the like pre-data or looking at that stuff, but so is the idea that we'll start like the actual first PDA cycle at the beginning of December?
You will get familiar with all the tools that we are asking you, and we will have more resources rolled out to you. So we're going to hit the ground running in January is the plan right now.
January. Okay, thanks.
Yep. Okay. Hearing none, I am happy to give everybody 2 minutes back. Thank you so much, everybody, for joining. Thank you for our presenters today. I will be in touch with you, but if you have any questions in the meantime, please don't hesitate to reach out. Thank you. Have a great day.